Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling lymphoma. Now, I want to give a little bit of a disclosure before we even go into our practice question today, and that is that the topic of our episode, lymphoma, is really broad. There are multiple types of lymphoma, staging, and just so many caveats that we are not going to get into. Why? Well, because we are focused on new graduate nurses going to pass the NCLEX. And to do that, you need to be a new grad with 2 weeks of general nursing knowledge. You're not going to be going on to an oncology floor and administering chemo because that requires a specialty certification. So it really wouldn't do you a lot of good for me to blab on and for hours and hours about the multiple types of lymphoma and this and that. I am going to cover high level, the basics that you need to know for your nursing exams. Okay. So if that doesn't sound of interest to you, then go ahead and skip this episode and head to the next one that does. But for those of you ready to pass those exams and get the info you need, let's jump into our practice question together. A nurse is caring for a 64-year-old client that was recently diagnosed with stage 2 non-Hodgkin's lymphoma, and they are beginning chemotherapy. During the first 24 hours of treatment, the client reports palpitations and weakness. The nurse reviews the client's labs. Ready? Potassium 6.2, phosphate 5.9, uric acid 10.5, calcium 7.2. Which of the following is the nurse's priority action? Is it A, to apply oxygen and place the client on a continuous pulse ox? B, to administer the prescribed allopurinol that reduces their uric acid levels? C, initiate neutropenic precautions to reduce infection risk? Or D, place the client on a cardiac monitor and prepare to administer IV insulin with dextrose? Okay, so tuck in the back of your brain what you think the right answer is, muddle on it for a second, and we will circle back at the end here to see if you can hopefully get to the right answer and understand why. First thing we're going to do is just break down overall what is lymphoma. It is a cancer of the lymphatic system, and that's basically the body's immune highway. The lymphatic system includes lymph nodes, the spleen, tonsils, thymus, and bone marrow. And what it does is transport lymph. Okay, what in the world is lymph? It is a fluid that is basically rich in white blood cells, all of our disease-fighting immune cells. And it filters out germs and helps us mount our immune response. So in lymphoma, some of those white blood cells, usually our lymphocytes, go rogue. Instead of following the normal divide, fight infection, and then die off cycle, they start multiplying uncontrollably. Now, there are two main categories that you need to know. That's your Hodgkin lymphoma and your non-Hodgkin lymphoma. Now, the big thing that differentiates this is that in Hodgkin lymphoma, we have the presence of a very funky cell called a Reed-Sternberg cell. These are large abnormal lymphocytes that basically act like bullies in the lymph node. They just push everything else around. Now, in non-Hodgkin lymphoma, we do not have Reed-Sternberg cells. So in my brain, I would remember like non-Hodgkin, not having those cells. Non-Hodgkin lymphoma is a diverse group of cancers, and it can behave very differently depending on the subtype. We ain't getting into those subtypes, right? Because we're not expert oncology nurses at this point. If you are, this episode would be really boring and you should find another podcast. Okay, but jokes aside, when we have these abnormal lymphocytes, no matter what type of lymphoma we have, they start to pile up. They pile up in our lymph nodes, and then our lymph nodes get really swollen. So often we have a client who comes in and they're like, I've got a lump in my neck or my armpit or my groin, one of those areas where we have lymph nodes. And here's a key factor. It is painless. It doesn't really hurt. They're just like, why do I have this lump here? And that lump is there because lymph nodes are getting clogged with dysfunctional lymphocytes. All right, that's just the beginning. Lymphoma definitely doesn't stop there. It can spill out into the bloodstream and then spread to other organs like the liver, the spleen, the lungs, even into the bone marrow. And that's where we need to talk about staging, which is really key for prognosis and treatment. As with all of our cancers, the stages start at 1, and that is the earliest. If we catch it at stage 1, that's super good. We're going to have the best prognosis. Down to stage 4, where the cancer has spread much more dramatically. Now, you do not have to be an expert in cancer staging, but here's the overview. Stage 1 lymphoma, we've got one lymph node, one area, or one organ above the diaphragm. This is a localized disease. Stage 2, we've got 2 or more lymph nodes. They are either above or below, and one node area plus one nearby organ. In stage 3, we have nodes both above and below the diaphragm, or node involvement plus the spleen. We have spread out to the spleen. And lastly, in stage 4, of course, this is the most widespread. One or more organs outside of the lymph system are affected. So that's things like your liver, your lungs, etc. Now, clinically, it's important to know lymphoma causes more than just swollen lymph nodes. The systemic symptoms that we classically think of when lymphoma are a fever, night sweats, and weight loss. Pair that with the painless swollen lymph nodes, and that is your classic lymphoma presentation. This all reflects the body's inflammatory response to the cancer. They're really fatigued because, the bone marrow is crowding out all of those normal cells and we can't make enough of our red blood cells. So we get real tired. We have a fever because our body is mounting an immune response to these dysfunctional cells, okay? So that's kind of the grouping of symptoms you're looking at. But big picture, lymphoma starts with misbehaving lymphocytes. We see it show up as painless enlarged lymph nodes. It can spread throughout that lymphatic system, and we stage it based on how far it's traveled. It lives in one of 2 families, our Hodgkin's, where we do have those Reed-Sternberg cells, or our non-Hodgkin's, where we do not have Reed-Sternberg cells. For you guys as nurses, recognizing those key symptoms that are really classic for lymphoma, the painless lumps, especially in the neck, armpits, groin, the fever, night sweats, the weight loss, those are going to be big red flags that you have to know and look out for. So with that being said, let's walk through a little case study here on a client with lymphoma. This client, let's call him Mr. Jones. He is 64 years old and he had a kidney transplant about 40 years ago. Now he has a new diagnosis of non-Hodgkin's lymphoma. So first assessment, let's go through some things that stand out. He's tachycardic to 120. He's pale, swollen lymph nodes specifically in the right axilla and his neck. Now, on auscultation, his lungs are clear, but he does appear to be fatigued, and his perfusion isn't so great with a delayed cap refill of 4 seconds. So the first thing I want you guys to think is, do these findings make sense given that he has a diagnosis of non-Hodgkin's lymphoma? What do you think? I mean, lymphoma originates in the lymphatic system, key player in the immune system. In this client's case, the malignant lymphocytes are proliferating in the lymph nodes and creating those swollen, firm masses that we noted in his axilla and his neck. What about the tachycardia? Did that make sense? The pale skin, the perfusion issue. It shows us his body's under stress, right? That could be maybe he's anemic from bone marrow suppression. The marrow is being crowded out by those malignant cells. Now, also think about his history of a kidney transplant. I know it was 40 years ago, but if he's had a transplant, he is on long-term immunosuppression therapy, so his body doesn't reject those kidneys. And that long-term immunosuppression increased his risk for lymphoma to develop. So to me, first glance, all of this is really making sense knowing his diagnosis. Now let's talk imaging, okay? Imaging showed the disease in 2 node regions. So his right cervical and his right axillary, which makes sense because that's where we palpated those lumps. So where would that place him at staging wise? That's stage 2. It's still localized. It hasn't gone both above and below the diaphragm or to other organs, but it does involve multiple node groups because we've already got the neck and the armpit going on, which helps us understand why he's fatigued. The right side of his heart is working really hard to maintain perfusion. So we've got these nodes going on up there, but he has a lower oxygen carrying capacity. So we have to support his function with what we've got to work with, right? Looking at baseline labs here, we want to get a CBC to check all his blood cell counts. We are worried about red blood cells, white blood cells, and platelets being low, given that those abnormal cells are crowding out the good stuff. We also want to look at his electrolytes really closely because chemo is going to be part of our treatment here. And we know there is a big risk when we first start treating this cancer for a complication known as tumor lysis syndrome. So, really quickly, because we didn't talk about this in the first section, when we have a cancer where there is a mass, such as lymphoma, we've got these lymph node masses, and the cancer cells get killed off really quickly. We start our chemotherapy and boom, we're knocking them all out. Well, those cells dump all their intracellular contents into the blood. Potassium, uric acid, phosphate, all the stuff inside of those cells get dumped into the bloodstream. So if he's in here about to get his first chemo, we need to know baseline what his electrolytes are, and then keep an eye on his electrolytes as we give that chemo. So we're not going to go down the rabbit hole of the different types of chemo and such. Remember, that is something that you need a certification to administer. But we have one of our oncology nurses working with us, and she comes and starts the chemo. You go back and check an hour later. We're going to repeat those electrolytes. And sure enough, we've got a high potassium. You hook him up to an EKG. We see that he is tachycardic. What is going on? What do we think that we need to do here? Of course, as we kind of just prefaced, this is a very classic presentation of tumor lysis syndrome. We treat that cancer, those cells die and release their contents into the blood. So to treat that hyperkalemia, that's going to be a big priority for us because that can mess with the heart and we got to get that under control quickly. The intervention we're going to use is giving D50, that's dextrose 50, some good old sugar, and giving it with some insulin, so that insulin can open up our cells and bring not only the glucose we're giving, but the potassium too back into the cells where they belong. Okay, we want potassium inside of our cells, not outside. And when those cancer cells died, they released a lot of it. So giving D50 with insulin will help us move potassium into the cells. Now, that is really important short term when you get that emergency of tumor lysis syndrome. But what are some other things we need to do for Mr. Jones here long term as he deals with his non-Hodgkin's lymphoma? First, we got to place him on neutropenic precautions. He is super immunocompromised. That means strict hand washing, no fresh fruits or flowers. We are really going to be limiting visitors. If his neutrophil count goes below 1,500, he's going to be at super high risk for infection. So we're really limiting how many people go in there. It's also important to know as a nurse, if you've got a client on neutropenic precautions with any type of lymphoma and you see a fever, that could be life-threatening. We know his immune system is really compromised and he is at high risk for infection since those rogue lymphocytes are kind of crowding out all of our good cells. So really, really taking a fever very seriously and starting antibiotics quickly if that occurs, very important. That's really true for any type of cancer. Now, other things to talk about, even though you're not giving the chemo, you might have a client who is being administered chemo and you're going to help manage all the side effects. So antiemetics for nausea, very common to use on ondansetron and Phenergan, as well as scopolamine patches. We want to be on fall precautions because if we have low platelets, thrombocytopenia, we're going to have a higher bleeding risk. We want to do daily weights to look at fluid status. We do careful hydration and electrolyte monitoring. That is going to be especially important given his complication of tumor lysis syndrome. We're going to keep a really close eye as we get that stabilized. And of course, this is a major interdisciplinary team effort. We need to make sure he is following up with oncology, getting referrals to nutrition and physical therapy so he can rebuild that strength, and giving lots of good education, not just to him, but to his caregivers as well. They're going to have a huge role in reducing his infection risk and recognizing red flags early on. So major team effort when it comes to any oncology clients, and definitely to our example, Mr. Jones here with non-Hodgkin's lymphoma. So all that being said, I'm going to circle us back to our practice question because it really is good at zoning in on one of those emergencies you could see as a new grad that you need to know how to manage. So I'll read it to you again. We have a nurse caring for a 64-year-old diagnosed with stage 2 non-Hodgkin's lymphoma. He starts chemo and 24 hours in reports palpitation and weakness. Looking at labs, we have a potassium of 6.2, phosphate of 5.9, uric acid of 10.5, and a calcium of 7.2. What is our priority action? Think back to the case study because this question is really looking at exactly what we just went through. Did we need to apply oxygen and put on a pulse ox? Administer allopurinol to reduce that uric acid? Initiate our neutropenic precautions, reducing that infection risk? Or placing on a cardiac monitor and giving the IV insulin with dextrose, our D50. You guys know what we did, but think why. Why is that important? The priority here is D. Get them on the cardiac monitor and start that insulin and dextrose because this is classic tumor lysis syndrome. The things I want you recognizing from this question are, first and foremost, we have a cancer with a mass, non-Hodgkin's lymphoma. They started chemo. Then they start to have palpitations and boom, their electrolytes go crazy. What's happening is we killed off that cancer and those cells lysed and dumped all of their intracellular contents into the client's bloodstream. So what do we need to do about it? Well, all of these things are a problem. We are going to give allopurinol to get that uric acid down. We're going to deal with the phosphate and calcium issues as well. But the priority is the potassium because that can mess with our heart, send us into arrhythmias, and ultimately kill our client. Whatever's going to kill our client fastest is our priority. So move that potassium back into the cells. IV insulin and dextrose is what'll do the trick. So remember, non-Hodgkin's lymphoma, not Reed-Sternberg cells. We get masses in those lymph nodes. They're swollen but non-tender. This is a cancer where we watch out for tumor lysis syndrome. And if we see that occur, our priority is going to be getting that potassium under control. Those are your key takeaways for dealing with a client with lymphoma. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.